And this is a patient now, photograph. You see hump, the doobie tip, under projected tip, acute nasolabial angle, columella show, hanging columella. So all the problem are there. Bifid tip, bulbous tip, bifid tip, as you see, bifid tip and bifid columella, bulbous trapezoid tip. So it's very quite difficult case. And also it's a revision. Patient already had nasal surgery 3 years ago. So you will see now how we are going to address this nose and nose reshaping. We start with the local anesthesia now. Okay. Now, the first thing we do, the first line, give me the local. So I don't see lateral osteotomy there. So we go there. And of course, you aspirate first. Make sure there's no blood. Okay, that's the first. And the second one along the upper lateral cartilage. And there to the nasal. Again, aspirate. And you see. Again, the third one now there, on this line there, here in this area. Again, aspirate. Slightly there. Aspirate. And you see. And now, last one on the side, on the where is to do about lateral osteotomy. Again, aspirate, and we'll do the injection. Then we'll go in between the two alar cartilages there, in the space, and aspirate. And you see now, because we're in the right plane. And then now to the alar base, hit the bone, aspirate. Again there, hit the bone, aspirate, and inject. Okay. Give me some more, because we want to do the ear, prepare the ear. Prepare the ear, just in case. Hopefully, I can feel some symptoms there. Hopefully, the symptom. Now aspirate again. Aspirate and see. That's it. So now we'll wait for about 10 minutes and we start the surgery in 10 minutes. Thank you. So we will just trim about 1 millimeter, not more. Up. Give me sharpness on that. Yes, in order, this is what contributing to the doobie tip, the elongated caudal septum, which I already am correcting.
Yes.
You see, remove from the caudal septum of the. And then also the next step is the long lateral cusp, but this will correct it later. The long lateral cusp is pushing the tip down. The long lateral cusp. So that's the two main factors. And also the strong depressor septal muscle, we deal with it later. Okay. That's why I said rhinoplasty is maneuver. Rhinoplasty is maneuver more than an approach. Now we go transcardiac incision again. You see, we stay medial. Don't go too much. You see, we don't go lateral. You stay with there fully lateral. You see, nothing lateral. You see. Again, transcardiac incision. Stop. Don't go lateral at all. Okay. There is no need to go lateral. You see, we are working. That's why the fullness there. I mean, there is no fullness there. So don't go lateral at all. Stay close to the midline all the time. This surgery, put it in your mind. This surgery, less healing process, less fibrosis, less scarring. So now we trim this different end. That cost will reduce the supraalar fullness. So by trimming this end of the lateral cross, You preserve the mucosa as much as you can, and trimming this. By trimming this, very important again. Not see, I fully preserve the valve. I'm not only reducing the fullness, also making space here allow for rotation, because you need space for rotation. So this one trimming this caudal, if I cut across, will reduce the fullness and give you space for rotation. We'll do the same on the other side. You see now it's keep the portion across, push the mucosa down and trim there. Again, this is that across there. From here. Still some more. A little bit there. But that's enough. So we preserve fully the valves there. As you see. All right. So now we need to deal with the hump. Okay. It is very obvious hump there. So always add a rim of some. Always remove half of the hump. Half what you think. Never try to remove what you think. If you remove what you think, you end into disaster. You end into augmentation procedure at the end of the procedure. Because, I mean, following removal of the septal graft and sometimes doing full septoplasty and following the osteotomy, they always might collapse. So always remove half what you think. Before we remove the hump, we just remove the periosteum from over the bone. Remove the periosteum from over the bone. And always preserve at least half centimeter of the dorsal, of the caudal dorsum septum. So now we see, we visualize the hump. You can see the hump there. You can very clearly, can you see the hump very clearly? Give me marking pen. So never try to remove the hump from the superior septal angle as most surgeons do. Always move back, and you see now what you think. You think in your mind you should remove the hump from here, but what I will do, I move the hump from half what I think. I remove it from there. So give me a line. Half what you think. Then if you need to do more, you can do more. But if you do a lot of at the beginning, it's one-way ticket. We divide now. Let me see. Divide now the cartilage, and now you see what I preserved here. I preserved dorsum septum, as you see. I preserved all this area of dorsum septum. Now with osteotome, it's a new one. You don't have the old one. I'll give my old one. I don't like to use the new one for the first time. Yep. So this 16 millimeter osteotome. We go under, you see, under the cartilage, and now after I make myself comfortable, make yourself comfortable, and make the osteotome horizontal to the face, and ask, yeah, gently. Okay. There's the hump under my finger there, and that's it. You see? That's it. The hump there. So don't remove much. Don't remove much. Now, some irregularity, we do it with rasping now. You see, that's it.
Yes.
Okay.
Yeah.
Go there. And when you rasp also, don't rasp like this, rasp like this. If you rasp like this, you are hitting this area and you cause autopodema after surgery. So always rasp obliquely. Rasp obliquely, the bone. I said, always conservative. You can do more, but if you do a lot at the beginning, you are in trouble. Now you see almost, if you look from the side view, the hump now almost has gone if you compare with this view with this view there. Still a little bit of muscle here, but still some bones there. Give me just hard shot. Yeah. Still some bones there. Just go with something more harsh. Who's one now? You can leave this to the end of the procedure, but now we do it now. Better do it now. You see now, almost excellent. Now with the tip projection, it will look absolutely fine by after we do the tip projection and after osteotomy. So final touch after osteotomy at the end of the procedure. Okay. There's still a little bit there. Yeah. Give me a knife. A little bit there. We just with knife. A little bit. Always remove a little. You can always go back and remove more. Don't remove too much. If you want to only little. Let me check again. Yeah, now it's fine. I've done. Again, do the final after you see now almost very straight. You do the final after osteotomy. Okay, we start our rhinoplasty now. Oblique dome division. So we hold the medial columella and watch for my marking, give marking pen. My marking was there. And see the lateral cross. There is kept alone. No marginal incision, no exposure, no delivery, kept alone. So we work immediately, as you see. Give me a knife. So we divide dome from medial to lateral, reserving the cartilage, as we said. Again, there, as we explained, marking pen again. Preserving the limb cartilage. The patient had previous surgery, so always some. So marking pen. So as you see, I preserved fully the limb cartilage here, from there to there, fully preserved. And this, as you see now, this is fully preserved, the limb cartilage. So it's very difficult to get notching. Once you preserve the limb cartilage there, very difficult to get notching here. And you see, fully preserved the lateral cross again, lateral cross fully preserved. No margin incision, no margin incision, no exposure, no delivery of the lateral cross.
Yes.
So that's why I mean, when you do the open approach or delivery, at the end you have to put limb graft here to avoid notching limb graft. So what's the point of cutting and putting graft again at the end? Does it make any sense? So that's not what we have done. We fully preserved the limb cartilage delivery now. Now we deliver both cephalic portion of the intermediate crural. You see now this is in horizontal position. Now it will be transformed to a vertical in a few seconds. But some fibrosis because tissue. Now we will, you see, both delivered to one side. See how symmetrical? Because marking, organized work, you work in symmetrical manner. But sometimes if the alar cartilage are asymmetrical, you cannot get this symmetrical. So it depends on the case. Especially in revision cases, the surgeons may have removed most of the alar cartilage. So it can be very difficult. That's, I mean, case number 4, I think it's a difficult case because surgeon had removed out of cartilage in the surgery number 4. So now we try to expose the caudal septum from here. I want to expose the caudal septum all the way down. I need to see the caudal septum. Yeah, that's it. All the way down. That's it. You can do all the same in open approach. You see, open there. And you can do the same in open approach if you want. Okay. Now, this is my graft. Extended columnar. So we need long one because the patient has got. Remove any sharp edges. Any sharp edges. And we need additional graft. Additional columnar and tip graft. Okay. So this graft I need now to use. I'm going to use. So this is, you see now, this is, you can't get any better than this strong foundation, strong cartilage to bridge between medial crural and caudal septum. Again, you can do all this maneuver in open approach. But what you do, so it goes there now, and we suture it to the medial crural first, and then after we suture to the medial crural, next step to the caudal septum. So first step to the medial crural. You see? Special thanks to Professor Dr. Khalid for his very nice elucidation and hypotension at the same time using the propofol. You see, very nice, keep clean. Okay, if you don't have BDS, you can use 6-0 Proline here. Any excess tissue removed to avoid any swelling and edema after surgery. So another bucket now, another bucket along the caudal margin of the medial crural there. You will get this. This is the beauty of this longer graft that you see it will augment the nasolabial angle for you. And when augment nasolabial angle, it will give you more rotation, especially in this patient with acute nasolabial angle. And longer graft will stretch the columella. It will correct any hanging columella or bifid columella or even retracted columella. So now very strong foundation in the midline. Again, all this maneuver can use in open approach. All this maneuver. Rhinoplasty is maneuver, is not really an approach. You can do the approach which makes you comfortable, but main thing to consider the maneuvers, especially in patient in our part of the world, skin type 4 and 5 according to Fitzpatrick. It's all the Arab and the Indian skin run under classification number 4 and 5, while African number 6. You know, number 1 is red hair and white skin. Number 2 is fair hair and white skin. Number 3 is white skin and black hair. Number 4 is and 5 is our skin and the black hair. Number 6 is the African. So now we'll push the structure to the midline. And you can see how immediately, look at this angle now, nasolabial angle, look. Look at the great transformation straight away, look. From acute angle, hanging columella, under projected tip. Look at this angle there, look at this view now. Look at this great transformation now straight away. Haven't sat still at the beginning of the surgery. Look at this nice
Yes.
transformation there. You see? Okay,
Yeah, very nice,
stretch columella. Almost we corrected 50% of the columella show. Nice tip projection, straight dorsum. We still a lot of work to be done, but I mean, see, you see now my graft section. You see my graft now? Can you see it?
Yeah, we can see it now.
This is the extended columella strut. So we just under section. You see, when to get overlap the caudal septum, there's a caudal septum here. You can see the caudal septum overlapping the caudal septum and will be sutured together.
Yeah.
Sutured together. Don't put too much suture because you don't want to perforate the cartilage too much, otherwise get absorbed. So just put the necessarily suture just to close the gap and to get the cartilage together, cartilage to cartilage. That should be enough. So 2, 3 times or 4 times maximum. Okay. Any excess of skin or tissue should be removed. You see all this one should be removed. Okay. That should be enough. Oh, that should be. Okay. So we fixed now the tip cartilage to the caudal septum. It's very strong foundation there. Okay. Marking it. You see now, at this nice profile, we're still at the beginning. It's already achieved nice profile compared to this profile before. Okay. So what we did now regarding the extended septal graft, this is the nasal septum, caudal septum, medial crural there, medial crural, and our graft extended columella came like this, and suture to the medial crural and suture to the caudal septum. So bridging the medial crural to the caudal septum. And then the skin will lie on top. Of course, there was additional columellar and tip graft there. So that's really very nice, strong foundation in the midline and fixing the alar cartilage to the nasal septum. Okay. Now we said the factors that causing dubi tip, the long caudal septum, which being corrected. Now looking at the lateral cross, you see quite large lateral cross, long lateral cross. So we need to shorten it. We need to shorten it in order to, first I will just refresh the edges. Refresh the edges. Okay. You see the beauty of this technique is that the cross is in place, no margin incision, no exposure, no delivery. That will reduce a lot of work, like, I mean, putting graft later there, rim graft, doing all notching, collapse, asymmetry. Now, we're going halfway on the lateral cross. Do lateral crural overlay technique, which can be done by, if you open approach, you go from above. Now, because close approach, we go from below. Give me that again. We just make small cut here, a few millimeter only cut. Okay. And then we get this first under the cartilage and then under the skin, sorry, under the cartilage over the vestibular. Very careful. It is very, very thin skin. You have to be very careful. It's okay. But you see very thin. You see, I'm under the cartilage. above the vestibular skin. All the way I want to get there. I want to get there, see? And open gently, open about half centimeter. But make sure you don't get the skin to tear. Even if it's torn, it's not really a big issue. Don't worry, it will heal nicely, but it will upset and make it a little bit difficult. I mean, complication can happen to any surgeon. So the surgeons who claim no complication are those who do not operate and honest. So complication can happen to anyone. Suddenly you may find this skin has torn, suddenly sometime. It's okay, you can suture it back. What's the issue? It will heal in a few days. You see now? Then we turn the scissor 90 degrees and we cut. We get to there. You see, get to there. And we cut. You see now? Overlapping. Overlapping, you see now? And this is now what happened. Overlap, we remove the sharp edges. It has been shortened now. By this overlapping, it has been shortened, you see? It has been shortened now. This type now is shorter. Look at the difference between two sides. First, of reduce the bulbosity because we broken the bulbosity and also we shorten the lateral crest. Give me my camera. Because you see lateral crest, this is the lateral crest there. So when we made this cut there, and when they get to overlap each other, so it's being shortened. It's being shortened. It's getting to overlap. So it's shortened now. Plus, we broke the bulbosity. Again, mark and bend. We broke the bulbosity there, being broken. Do the same on the other side now. Now this is endonasal lateral cooperative technique. You can do it an open approach. I think we have video for open approach, right?
Yeah.
Yeah, we have video. We show you now after the case the video how you do it in open approach. So you can do it in open. Now refresh the edges here again. Move those this. And then we'll go halfway. We'll go halfway on the lateral crest again. And knife first. You just chop there. Okay. And then we'll go first above the cartilage, then under the cartilage and above the vestibule. Again, gently. Again, circulation there. And now open very gently to avoid tear. You're almost now, yeah, almost 1 centimeter or more. Yes, or just like that's enough. So then we turn your scissor 90 degrees. And divide. Okay. You see now again overlapping. You see the overlapping. Remove the sharp edges. You see now how beautiful. So we got two benefits. We broke the convexity, plus we shorten the lateral crest. This is a key maneuver in the dubious tip. You see now the more rotation, the tip is more comfortable now. More rotation, more backward rotation. Give me some suture. Now lateral crest approximating suture. We'll go through the superior occipital angle here. 1 5 another. And then we'll go. So I did my lateral cooperative technique. But I will get small bite here. And then additional small bite there. You push it in. You see now? You see the effect of suture? In with the preservation. So this is really preservation. Lateral cooperative technique, preservation. We did not remove any portion of the lateral crest. We remove only the sharp edges. but we did not remove any portion of the lateral crust itself. We're going to overlap. Put this one down. Clean. Again, when we did our lateral overlay technique. Enough. Push one. Push it back. Yeah. This is a really beautiful case. See now, we transformed a bulbous bifid tip into a natural looking tip with reservation of that third class, reservation of the alar cartilage, working mainly on the midline, as we have seen. Look at this extremely beautiful profile. Look at this. And compare with this profile. Give me facial after.
Yeah, beautiful result.
Yes. Now, let us do osteotomy. You see now, look at the tip. I want to see the tip from base view. Look at this tip from base view. And look at this tip from base view. Look at the boxy tip, the bifid tip. All has gone. Boxy tip, bifid tip. Look back to the base view here. Look, the great transformation.
Yes.
From above, you see from above, this definition, refinement, with the full preservation of the cartilage. Look at this difference between here, and look at this great difference now. You see, great transformation with preservation. How much for each side of the cartilage? Show me what I have each side. We'll do osteotomy now anyway. We'll do osteotomy to close the gap. Lateral cross, show me. That's all what Alex side really there from the lateral cross. All the side actually. From the tip cartilage. All only this. The small piece of the rim of the caudal septum actually. Very small piece, yeah. That's it. Of the caudal septum. This from the caudal septum. Okay. Actually, this is the future. New generation will convince that this is best simplified technique, preservation technique. You see now, most surgeons now, after they do the hump, they put spreader graft there. I don't know why. How they destruct and then reconstruct at the same time. Why do you destruct if you want to reconstruct? Give me one thing there. I get you what my point. Now, this is the dorsum of the nose. Okay, you have in the middle the nasal dorsum septum. You have the upper lateral cartilage, right? And you have the lower lateral cartilage there. Okay. Okay. Lower lateral cartilage. Now, when you move the hump, what we did now, we preserved this piece. We did not remove anything from here. We removed the hump from there, half what I thought. I removed this one. So I preserve this piece of dorsum septum. So when I preserve this piece of dorsum septum, the upper lateral cartilage This is the dorsal septum kept. They were attached here, attached to the dorsal septum. So they kept arching like this. So they kept arching like this. So still away from the dorsal septum. But when surgeons, they do cut like this and cut like this, of course, then this one will collapse in, and then you need to put a spider graft there. So this is the point. Why you destruct and then reconstruct? It's a concept. It's school, new school. So it's really a great opportunity for you today to to have a look and expose to such a school of thinking, of logic thinking, of preservation thinking, of anatomy thinking. Not tuk, cutting. Open, nice approach. Oh, beautiful, very nice. Look, I open the nose, open approach, very nice. Everything looking nice. Look what happened to the nose after 18 months. Please. Okay. Now, in order to get rid of such irregularity here, we will just now use a right fascia lata. Where is the fascia lata there? You can show. This is the thing which when you keep it in place. Why did you move it? Keep it there. Fascia lata, the homograft, and this is the company there, the homograft. You see, the fascia lata, right fascia, same company. And also sometimes we use, in some cases, subo. Okay. This is right fascia lata. Already I prepped it for the brain. So it will go there to cover any irregularity on the dorsum. You see now is this. Okay. We take photograph for any however step we take photograph for medical legal. Okay. Now we'll push it in place. This will form nice sheet on the dorsum. Yellow. Quickly. Open the yellow one. Thank you. But I need. Sometimes staff don't get the things ready in the right time. Give me the needle, please, quickly. Just put stick needle there to make sure that the graft will not come out with my forceps. Okay. You see, there's a casting clip. And with this one, just might make sure. Okay, it's lovely now. Nice. No, it's just fine touch there. Fine. Yeah, that's it. See now, that's what I was. There was some little bit of fullness. I got rid of it. See now, absolutely straight now. Absolutely straight. Beautiful. You see now, really. We are done. We are done now.
Yeah.
We are done.
Wonderful.
Yeah. Yes. How many minutes? So you see the time? You see the time? 39 minutes.
Yes.
40 minutes. We have really transformed. Touch nose, boxy tip, bifid tip, trapezoid tip, hump, droopy, under projected, short columella show into such nice profile as you have seen now. Extremely nice. Now, last step only, I will just divide the depressor muscle because this is one of the factors again contributing to the droopy tip, this over or hypertrophied depressor subthymus, the nasal spine. You can see the nasal spine very clearly there. And with the simulator, just scratch the muscle there, scratch the muscle, scratch. Again, you can do this for doing open or closed approach, whatever. Again, rhinoplasty is maneuvers. You know. Okay. I'll get one suture just to hold the muscle up. So the muscle, we don't want the muscle to go and return back and heal and reinsert to the same place. So it will be because healing is going to happen again, and the muscle may retain its function. So we get to heal in a higher plane, so to keep the nose up. You see what I mean? Look here. Look. You see? Okay. This again my suture, my technique. It's called, I call it nose lift. The same what you do. The malar lift. Do malar lift there. Mini suture again. It is a two-foot blade together. Yeah. Fine suture. Actually, when I corrected there, I think I cut the spinal suture. So I will do it again. That's maybe good for you also to see the spinal suture again. But I scored. So when I did this fine touch here, the spinal suture being cut. So we'll do it again. Very quickly. Okay. Now it's still here. It's okay. Let me check. Yeah, I think it's on one side. Okay, point of one side. Anyway, we'll do it again. Always do the affection. Don't ignore anything. If you have something goes wrong, just fix it straight away. So we'll do it again. I said problem can happen to any surgeon. Surgeon who claim no problem are surgeon who never operate. So let us cast approximating suture again. With the cephalic cross, through the cephalic cross. And this would also will look for you the lateral cross overlay technique. It will look it for you. It will fix it. You see now the beautiful result at the end. Okay, done. Okay. So I want you now to compare base view, upper view. You see the lovely at this base view here. And look at this base view there. The boxy bifid trapezoid tip. And from above, you see the boxy bifid trapezoid bulbous tip. And look from above here. You see the great transformation Very nice, natural looking tip. Again, from the side view, look at this great transformation from there to there. So we already done now, as you see.
Yeah,
So,
wonderful result.
Yeah, if you give me now about 5-7 minutes, I will just write the patient file notes, do the dressing, and I will meet you there for continue the presentation. And we take some questions. In order to avoid the recurrence of the droopy tip. That's what again emphasized. Rhinoplasty is maneuvers. So the lateral crural overlay technique will treat the droopy tip, the bulbous trapezoid boxy tip. How we treat the bulbous trapezoid boxy tip? Also, they have a short lateral cross because it breaks the convexity. Because you need to break the convexity of the lateral cross in bulbous or trapezoid tip or boxy tip, then you have a bulbosity, and you need to break this bulbosity by doing that crural overlay technique. So this is the indication: break convexity, shorten lateral cross, reduce volume of the lateral cross, rotate the tip, avoid excessive trimming, and preserve the lateral cross. Because there is no point to keep excising the capital cross in order to reduce the fullness. So we reduce the fullness by a lateral overlay technique, in which we preserve the lateral cross and we avoid any excessive trimming of the cephalic lateral cross. So you see what I've done in Indonesia now, and I will show you how to do it by open approach. In Indonesia, what we have done now, you see, we marked the lateral cross halfway, and we went under the cartilage above the vestibular skin, as you see, all the way, we open for about 1 centimeter, and then we turn the scissors 90 degrees and we divide the lateral cross without over trimming. We trim only the sharp edges, avoid the sharp edges, but we do not really trim any of the integrity of the lateral cross. You see now, by doing this, we reduce the fullness. If you look now from above, you see now the fullness has disappeared compared to the right with the left side. The right side, no more fullness. Again, in the left side, again, we go under the, first above the cartilage, and then under the cartilage and above the vestibular skin. When we do it in Indonesia, but we can do it of course, do an open approach from above. Again, we move this sharp edges, as you see, sharp edges. And then you either do a locking suture, you can suture it to keep it overlying each other, or do a cross approximating suture in which you can lock it and squeeze in the lateral cross, especially with thicker skin patient like this patient. So for example, now this is an open approach. We do the same halfway of the lateral cross, and then we go under the cartilage above the vestibular skin, slightly on both sides. You see, we divide the lateral cross halfway in open approach, and we got it to overlap each other. We are above the vestibular skin. You see, and again, remove all these sharp edges, remove sharp edges. You see, again, the other side, halfway of the lateral cross, divide the lateral cross, but preserve the vestibular skin, go under the vestibular skin gently on both sides to get to overlap each other, overlapping each other. So you see, again, rhinoplasty is maneuver, not approaches. So we can do this lateral cooperative technique either by open approach or by a closed approach. And you can see now the difference between the two approaches, how much easier and more clean, more nice, and less invasive when you do it by closed approach. So now we spoke about the lateral cross overlay technique. There's also something called medial crural overlay technique, which done for over-projected tip. When you have over-projected tip, of course, that means that the lateral, the medial crural is long. So it's against the droopy tip when you have the medial crural is short. In over-projected tip, the medial crural is long, so you have to do the medial crural overlay technique the same way in order to get the two ends of the medial crural to overlap each other and get the tip slightly down. So the same principle.
Again, you see, we go halfway on the medial crural, halfway on the medial crural, as you see. Quite long medial crural because you over projected tip. We go halfway. And again, you go under the cartilage above the vestibular skin. And this is really apply the same, whether it is open or closed technique, we'll be doing the same things. Either an open or closed technique, we'll be doing the same thing as we do now. So you go under the vestibular, under the cartilage, above the vestibular skin, towards the apex of the tip, and then you get it to overlap. Keep the lower end stable. So you see now, it's become short, has been shortened now. And then you fix it with suture. You do the other side, and then you fix it with suture in order to fix this. This is the desirable length you already obtained. So again, divide the cartilage, run under the cartilage and above vestibular skin towards the apex of the tip. Keep the lower end intact in order to keep it stable, to keep the medial crural stable. You see now it's being shortened. And then what we do, I usually do put a columellar strut in between and suture all the structure together. You see, I see with the columellar strut. This will obtain your goals and correct the over projected tip. Lateral cusp approximating suture, you have seen really 3 times, no need to do it again now. You have seen 3 times. Leveling the bursal septi muscle, you see, I've seen it again now. For this patient who have this, you see, same case which we done now, exactly under projected tip, droopy tip, short columella. So we sublabial identify the nasal spine and then scratch away the bursal septi muscle. As you see, this will reduce the tension of the tip because people from our part of the world, they have really a powerful oral muscle. Unlike people Caucasians, the Caucasians, they don't have, thick lips. They have thinner lips and less powerful oral muscle. Why our people, they have more powerful oral muscles. So they really try to put the tip down by each movement of the lip, which the lip moves thousands of times every day when during talking, laughing, eating, drinking. So this is excellent technique to reduce the tension of the tip and obtain a sustained tip projection. You have the graft here. You have the graft. The additional key maneuver are steroid injection, kinocort, triamcinolone for cases of thick skin, which we use it regularly on thicker skin patient, starting 1 month after surgery and on 6 weekly interval, at least 4 times. This will really significantly improve the tip refinement and narrowing and definition in the thicker skin patient. Again, BRB, plasma-rich platelet are quite useful for people who have problem with healing. Again, with hyperbaric oxygen, for people who have really problem with healing, people who had, for example, chemotherapy or radiotherapy, or people who are diabetic. So this, BRB and hyperbaric oxygen can be helpful in such cases. You see, for example, great transformation. Look at this, symmetry, which we obtained following such procedure, 18 months following surgery. Look at this again, very natural result. As you see, nice tip projection in the patient. Look at this nice tip definition and refinement and narrowing you obtain with such technique. Look at this one with deviated nose, droopy nose. Look at this great transformation. You see, again. Anyway, so we want to show you the video about the graft because you wonder about the warping. So I show you a video how you can, as much as possible, reduce the possibility of the warping. Can you hear me?
Yes, yes.
Okay.
That was nice presentation.
Now we'll show one video now, then we take some question.
Yeah, there are a few questions.
Yeah, one second.
If there is
the graph, and then we'll
the-
take it from there. You know, 10 minutes, yes. Just move the video stop. Move the video. I'll go back to it. Yeah. See, if you watch this video now.
I'd share the screen.
will you be able to show us the video on rib
1 second.
carving? Yeah.
We can see now. So we
Yes.
have a dried fascia first, we put the glue, and then we put the homograft as you see. And then I'll mark it, and then I score it. You see how I score it this way? First, I score the graft vertically, and then I score the graft obliquely, as you see, obliquely, and then score it again obliquely on the opposite direction. And then we will adjust. You see now, the aim of this to get the graft to ride on the septum, not to sit on the septum. And then we will just rub the graft with the fascia, because by rubbing the graft with the fascia, you reduce the warping because it will stick in. So now because we scored this, it will become like the tiles on the floor. And then now I press it with my finger, as you see. I press it with my finger. Now I will break all this particles, you see. I'm pressing with my finger. So I'm breaking all this particles. So it will be riding on the dorsum, not sitting on the dorsum. So when it rides on the dorsum, the same of the saddle, when it rides on the horse back, you see now, dorsum, and this is the graft there. So if you don't do this scoring, what will happen? The graft will warp to the left or warp to the right, the graft. But when you do this scoring, and like the tiles on the floor, and then we break this ties, because already fixed on the fascia with the glue, so the graft will ride. You see, will ride on the dorsum, and you will not see.
It's the case of the sudden nose, which we use the homograft, rib homograft, and we did cross-hatching of the graft, as you have seen in the video. And you see the big difference between now, before and after, really. It's extremely very nice results. And we did the cross-hatching of the graft there. So you cannot see any edge of the graft. It looks quite natural and no demarcation, as you see now. Extremely nice profile, nice projection, nice dorsal projection, nice tip projection, nice base, and very nice profile and tip projection and dorsal projection. It's really an excellent technique. Operation lasted about maybe 40 minutes only.
So, the option. Okay.
Show the graph.
Yes. Okay. So, do you want to take any question now?
Yeah, there is only one question about the cartilages. Do you preserve the cartilage
Sorry?
rotedly? So, and how to preserve the cartilage? Yeah, even the delegates wanted to know details about this support and the facial, even the facial data is not available with us, irradiated.
Okay.
And do you preserve the cartilage? And how to preserve the
my
cartilage?
choice, the homo rib, the fascia lata, and recently, I've been using the Subor after long discussion with the Professor Ashish, because he used it in the ear. So I thought, why, if he's using it in the ear and he's getting no rejection, why should I not use it in the nose? Actually, if you think of the advantage and disadvantage of each one, first of all, I really have no commercial interest at all in the Subor. I have no interest commercial at all. I'm saying really my heart, I'm saying my honest opinion, because I just been using it actually for the last 12 months almost, and we had no problem at all. Only one case of rejection, only one case. Now, if you compare the advantage and disadvantage of the other, you find that really this synthetic material has advantage on the homograft. Why? Because with the autograft or homograft, what will happen, as I said, it will warp, it will shrink, it will change its shape to C shape and deviate. Why this kind of a graft, it has a micro holes. You see, it has a micro holes inside, and then the tissue grows inside, and it has a rough surface. So usually it's stabilized in the midline. It's very difficult to move or float or warp, because it has a rough surface and will stabilize in the midline. It's difficult to shift, and then after a few weeks, the tissue grow in between these micro holes and fix it more. So they have really, the company offers 3 thickness, 3 millimeter, 1.5, 0.48. Also, they have 0.4 material. And sometimes you can use 2 layers, as you have seen here. Again, I have no commercial interest at all in this material. I'm saying my experience. If you put the advantage of this material and the advantage of the homograft or autograft, and disadvantage of this material and disadvantage of the homograft and autograft, at the end you find this material is really superior. Even if you have one case of rejection, is nothing over a year, because with the autograft or homograft, many patients we have to do revision, and we have to remove the graft, put a new graft, the graft shrink, the graft change its shape, the graft warping, and the graft floating, the graft going to the right and to the left. Okay, so but anyway, the 1 year follow-up is quite short. You have to look for the future. But as I said, I mean, the trick, what Professor Ashish said, that you keep adequate thick soft tissue on top of it. So when you want to put such a graft, you have to, when you do your dorsal undermining, stick to the cartilage and to the bone. So keep the mass above you and keep adequate thick tissue. Plus, only use it on the dorsum. Never use it, never ever use it on the columella or on the lateral crust. Never. It will reject. Not only this material, any material. I said at the beginning, any synthetic material, if you use it on the tip cartilage, it will eventually reject 100%. Any homograft material, if you use it as a columellar strut, or if you use it as L-shaped graft, any homograft, it will eventually absorb. So for tip cartilage, for L-shaped cartilage, for lateral crust augmentation, for supratip augmentation, you need to use automation autograft.
Which we use the homograft.
For dorsum, you can use homograft, and you can use a synthetic graft. Is not a problem. Put back to me. Okay. So, any more question?
Let me check. No, other than that, do you autografts anytime? Do you do you preserve the cartilage?
Sorry?
For another patient, do you
Yeah.
use cartilage taken from one patient do you
The
preserve
second
it,
patient-
use it
second
for the
patient,
second
in both patients this morning, we use autograft. We use the same patient on the graft. First patient, we use her nose and her ear, and the second patient, we use his nasal septum. So we did not use any foreign material today, or any homograft or any synthetic until now.
Not routinely also. Other cases you don't use.
Maybe case number 4, I don't know. Maybe because I need superative graft. If I don't find it, because it's revision, patient already had 2 rhinoplasty before. If I don't find adequate graft, maybe I use a homograft for the superative in the patient number 4. Now the next case will be transconjunctival approach blepharoplasty. And
Yes.
main thing, when it is indicated, really transconjunctival approach, is indicated to treat the fullness, only the fullness of the lower eyelid. If patient have any redundant skin or excess skin, then you need to do the open lower blepharoplasty, or do combination of both transconjunctival approach and the skin pinch technique, and the skin lasering after surgery for patient with excess skin. But for the patient now you see today, he's quite young patient. We have many patients in their 20s, early 20s, we do the lower transconjunctival approach because it is a genetic problem. It's inherited from the parents or from the grandfather or grandmother. So we do this transconjunctival approach in young patient and elderly patient. In young patient is really main etiology is genetic and hereditary, and in elderly patient the main etiology is the aging process. So today the patient around 27, 28, and he has got the genetic problem, the fullness, and you see how we approach from behind the eyelid without any cut and any incision, and really offer an excellent results for, and very natural looking. Now, even actually the new trend in the USA now, many surgeons avoiding the external approach, even in patients around the age of 60 or 70, because of the problem of the external approach of the ectopion and lower eyelid retraction. Because the fat is usually behind the orbicularis ocular muscle, behind the muscle, the fat. We have, the anatomy, the skin, the muscle, and then the fat behind. So when you do an open approach, external approach, you need to cut the skin. We need to cut the muscle in order to get access to the fat. And then when you finish, you need to suture the muscle and suture the skin. So the muscle, it's a fiber, elastic fiber. So when the muscle going to heal in a few months, it will happen. Some patient has severe contraction, and the severe contraction will pull the lower the lower eyelash down and cause the ectopion and the retraction of the lower eyelid, because of the healing process. It has nothing to do with the skills of the surgeon. So therefore, when you go transconjunctival approach, then you are behind the muscle, behind the orbicularis ocular muscle. So you don't touch really the muscle, and you don't cut the muscle, and you do nothing to the muscle. So combination in elderly patient of the transconjunctival plus the pinch technique. The pinch technique means to excise only the excess skin, not the muscle. So if you do the skin only, you very rarely get ectopion, because the skin is usually nice. And then in order to get rid of small wrinkles and fine lines, now the best technique is the fractional laser. It's not really the CO2 laser, it's the erbium laser. In particular for people from our part of the world, the skin type 4, 5, and 6, the CO2 fractional laser will cause pigmentation in high chance. Why now the new technique, the erbium laser, is really excellent, and usually it causes no pigmentation, and is the best for our skin, for skin type 4, 5, and 6. The erbium laser, erbium fractional laser. So it's a fractional, so it's erbium. So we usually do it routinely after blepharoplasty, after face and neck lifting, we routine at 6 weeks after surgery, and we repeat 4 times on 6 weeks interval.